Hello and welcome. I want to start with a personal example today. Got to make sure my mic's on. I want to start with a personal example. About, I'd say 6 or 8 months ago, my ex, who I'm good friends with, was at my house. He's had some health problems and he could barely walk. He could barely get up out of a chair. He ended up relatively quickly getting a steroid injection in his spine. And ever since then, it alleviated the pain enough that he could start to move around, get exercise, lose some weight. And now I'd say 8 months later, he is doing great. And I'm really, really happy about that. But what happened to him is one example of, if it weren't for that steroid injection, I don't know where he would be right now. And this is one example of what may be coming January 1st with some big changes in Medicare. So I have invited someone to be on with me today who I can't think of as better qualified to talk about this, because he's an MD. He is a former insurance company, health insurance company executive at a fairly high level, or a pretty high level. And in addition to that, he owns a company that builds AI. And I'm going to explain why that's so important. So I want to welcome Dr. Dan McCoy, or Doc Dano, as I would call him. Welcome, and thanks so much for joining me.
Well, thanks for being here. I'm excited. This is a great topic.
And I know you're passionate about it for a number of reasons. I just want to start out. You wrote, this is called WISER. That's the acronym that's coming to Texas and 5 other states as a test coming January 2026. And you wrote that what this is a computer algorithm trained by a for-profit tech company that gets paid to deny your care, will decide whether you need a procedure. What in that statement is concerning most to you out of that entire statement? What most concerns you?
I think the biggest thing that concerns me is that whenever there's really a foundational shift in the way that people have a healthcare offering, then you have to step back for a second, wait a minute, say, okay, is this shift actually a good idea or not? And I think the problem I have with this program is that the traditional Medicare, and let's define what that is, just so everybody's on the same page. Traditional Medicare is what your parents had. It's what probably to some of us, maybe our grandparents had a little touch of it. It's the thing that people know that when they turn, anywhere from like 62 to 67 in that ballpark, they can get on Medicare. And people often see that as like, I made it. I don't have to worry anymore about healthcare costs anymore. I'm kind of good to go, right? And Medicare has always been on this premise that here's the benefit, go use the benefit. It's not been like somebody's going to question your use of it. Nobody's going to do that. Now, you could argue that maybe that's led to some overspending. And certainly that created Medicare Advantage programs, which are really traditional insurance that's sort of backed by Medicare. We're not talking about that today because those are insurance products, and everybody knows what an insurance product is. An insurance product means that you're taking on some additional rules and responsibilities in exchange for some lower cost.
You kind of go in knowing that when you're dealing with insurance,
Right.
that there are going to be
Going in.
barriers. Yeah, you know that.
You know that going in. But in traditional Medicare, most people don't, patients at least, like your ex who got the injection, it should have never crossed his mind, if he's on traditional Medicare, that his just treatment would not be covered. Now, well, let me say something. His doctor could have gotten in trouble if the doctor has done something they shouldn't be doing. And clearly that was how Medicare did the enforcement. They looked at post-treatment claims and decided whether or not it should be covered. But the only person penalized there was the provider, not the patient. Now we've put the patient ahead of the bullet, not after.
Okay, let me ask you. You mentioned that some of the way Medicare was structured, particularly now, there are so many more things available that we can do in terms of medicine, that could have led to some abuse or overuse or things like that. What, in your opinion, is problematic about this way of allegedly addressing that?
Well, I have a lot of problems with it, just to be fair. So there's not just one. I have quite a few problems with it. But the biggest single problem I have is that there are, in a traditional insurance product, most insurance companies would have never gotten away with this. There are rules and protections in place for people that get prior authorization and approval for treatments. Yes, I know people kind of live in the world that, insurance companies have somebody sitting in the background that hits deny, 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 deny. But in reality, what's happening is somebody is bouncing that against an approved medical policy that is published and everybody knows what it means. There are, 2 or 3 levels of appeals that are easily baked into the system so that people know what the opportunities are. You can even appeal outside the insurance company if a decision is turned over. There are tremendous amounts of oversight here. Whereas in this particular system, again, what we see today, where again, the rules maybe will change and we'll get more insight, but it appears that those decisions of denial, which it looks to be by an algorithm, and then the whether or not it gets approved or not will be by company employee, and then the company will then profit based on how much waste they have. That's just code word for saying how many of those procedures get denied. And to me, I have a problem with that approach. I think that's goes against everything I believe in about taking care of patients.
So, what I hear you saying, I think, is that as a former insurance company executive, you are saying that and most of us, frankly, me included, hate the whole prior authorization thing in insurance. I'm not a big fan of insurance companies, just to be frank with you, because I feel like I pay and I'm sure a lot of people feel the same way. You pay what you're supposed to pay, and then, oops, we don't cover this. We don't cover that. You have to get approval for this. You have to get approval for that. But what you're saying is that, in your opinion, as a former high level insurance company executive, this program that the government is about to impose on Americans, on seniors, doesn't even have the safeguards that an insurance company doesn't have the rules an insurance company would have had to abide by?
What I'm saying is, I don't know if they do or not. We haven't really seen a lot of transparency, or at least I haven't been shown a lot of transparency on what are they actually following related to medical policy. So you mentioned spine injections. There's some data out there, quite a bit of data to show they don't do anything that much long term. But the problem was many of the procedures that are on that hit list, which are on that Wiser hit list, these are issues that patients deal with every single day. They're going into the doctor's office, they're sitting down in the doctor's office, they've got chronic pain, it's debilitating. And by the way, there's not a lot of options for these treatments. There's not. So physicians sit in the room trying to help their patient. Are physicians, profiting on these procedures? I'm sure there's fraud, waste, and abuse. I'm not going to say that at all. But intermixed with that fraud, waste, and abuse are patients in pain. And I think the problem that I have is that I don't know what the rules are. I know what they are on the insurance side. And I know that if an insurance company came out and said, we're going to put in AI that's going to deny claims, and then somebody within our company is going to be the only person to determine whether or not that's, going to be approved or not. And guess what? If we deny it, we're going to profit from part of the take. I can tell you that I'll be hauled before a federal committee. That would never happen because the rules aren't that way in private insurance. Again, here, I don't think we have a lot of insight. Now, maybe that'll come out, but right now, I'm concerned.
Right now, the way you read what you read right now, you don't
Right.
see that in place. Talk about, you mentioned
Mm.
knee pain. What are some of the procedures that are fairly common that this is going to affect?
Yeah, so let me just pull them up over here on my computer just to make sure I stay on task, right? So there's several neurologic treatments, and honestly, almost all of them require some sort of electronic, expensive medical device. So you can sort of see kind of where they're going. Some of them are relatively new. Some of them are, have been around for a while. But let's pick one of them: deep brain stimulation for Parkinson's disease. Horrible disease. Horrible disease.
Horrible.
Okay. Devastating, and I would argue terminal disease. So again, if you could, is this going to work in everybody? I don't think it does. But the point is, if you can save someone's life with a medical device, should you do it? And I would argue this is not a $3 million device. This is a typical medical device. Pain management, steroid injections, like you mentioned, and nerve tract lesions for people having serious pain. Again, lots of probably questions about whether or not these offer any long-term benefit. But here's the problem. In alternative, what do we do? Put people
Well,
on narcotics? I mean, I
and
don't know what the answer is here, right?
And regardless of whether it offers long-term benefit, I know that in the case of my ex, it offered enough short-term benefit that he was able to start getting some exercise, which gave him the incentive to start losing some weight and do all the other necessary things. Whereas he will not be as much of a burden on the healthcare system now with that one injection as he might have been had he not gotten it at all. I mean, I can see that example.
And I think that's the point, is that, where insurance companies get in trouble. I mean, I'm talking about trouble, but where it's challenging for an insurance company, it's challenging for anybody. When you start to review a medical chart and you put people into an algorithm, that's not the person sitting across the table. So my dad, I'm not famous over this, but I was on NPR over the death of my father. He died at 94. He fell on a ranch and broke his hip. He died 4 days later in the hospital. And I said this on the NPR story, that it's a 94-year-old who broke his hip and died in a hospital 4 days later. The statistic on that would be that, well, he's an elderly guy who broke his hip. But my dad ran a ranch until he was 94. My mom is 92 and still drives and goes to church every Sunday and prays for me. I mean, my parents were very, very, very active. My dad ruptured an aneurysm at 85 and had a do not resuscitate order that didn't get looked at, and he got his aneurysm repaired, and he lived 9 more years at 85. The point I'm trying to make is these are hard decisions. They're not easily algorithmic decisions. These are real patients' lives you're dealing with. So, having said that, you still need to have rules and algorithms, but you've got to have really strong guidelines, and really, to me, not a financial motivation on making those decisions. I know people look at insurance companies like it's financial, but in reality, that's not what happens. What happens in an insurance company process is that medical directors, usually at some degree specialists, if you get an appeal, they're following a policy and they're trying to see, does the patient meet these criteria? And at the end of the day, that medical director and that insurance company are going to get paid the same, whether or not that person gets the treatment or not.
But as I said, many of us who are not involved in insurance companies, frankly, I mean, I think what I'm saying, and I think what you said earlier when we spoke about this, was that this is actually one of the most unpopular parts of private insurance that's now being brought into Medicare.
It is, and that's my other problem with it, is that it's unpopular. It's also, and let's be frank, it's difficult to navigate. So if you get a denial, you are forcing at that point either the provider or many times the patient to engage in, arbitrating that decision one way or the other. So again, back to my mom, she's 92. She's sharp as a tack, but is she going to be the right person to understand, why her procedure was denied and who to call and all of the things that have to be navigated in that? And again, I don't know if there are customer service programs being built to the system. We don't really have clarity on that yet. But that's one more thing that really annoys me about this program.
Well, one of the things that I see as being most problematic, I mean, I just started Medicare about 6 months ago, I guess, something like that. I am a fairly well-read person with a lot of determination to attack issues. And I find it, as it is, very difficult to navigate. Very, very difficult to navigate. So if I'm looking at someone who is, let's say, 10, 15, 20 years older than me, who's alone, who's trying to navigate a denial for something that they need, I think that's a fairly bleak outcome.
I do too, and I think the other thing I had a problem with it with is that there was this overlay of like AI will be making decisions, and as the AI kind of I'm a big AI hype supporter. I believe in it. We build
You do,
tools that do
yeah.
that. I do.
Which is one
I
reason
think
I think you're great to
it's going to
talk about this,
transform the
because you
world.
understand it.
I think it was kind of it puts a black eye on AI because it's for two reasons. One, these systems are evolving. I don't know. Again, I don't have any insight onto what the AI systems that they're actually using there, but most insurance companies have had systems in place to do this for 2 decades through algorithms, meaning that if you met certain criteria, it just went on through, there wasn't ever any question about it. So I have to believe that some of these kind of concerns are actually built on algorithms. They're not actually built on AI. So to me, it kind of gave AI a black eye in that regard. And I don't know how much AI is being built in these systems, but I know this for a fact. The AI is not the person sitting across the exam room from that patient in the office, knowing how functional that person is, how much pain they're actually in, how, what goals and dreams they have that could be accomplished. Do they have the ability to get exercise and lose weight and get back on, or is this person just in terminal pain? They don't have that. They don't have that knowledge.
There are 2 or 3 items that you wrote a blog about this, and I wanted to hit on these. One was what you called the bounty hunter business model. What do you mean by that?
Well, I don't know. I mean, I wrote that to be obviously a little clickbaity, right? About kind of get people, don't jazz people up about it. Because, when you start to write an article about Medicare payment, let's be blunt, not a lot of people are going to read that and be excited and turned on. To me, it would be like having bank robbers, right? So somebody robs the bank, and then, you basically hire a group of bank robbers to count the money. And then if they find that there was money stolen, then the bank robbers split the money. That's sort of where I'm going here, is that what I meant is that you've got a system in place that is rewarded for making denials. Now, I would argue you should be rewarded for better health outcomes. You shouldn't be rewarded for just financial reasons. Financial can be a component of it, but obviously you should be rewarded for having people having better health care outcomes. And that's kind of what I meant by that bounty hunter statement. And I've got
This
experience here too, because they've done this before in another system. And I've seen this process happen. It didn't affect patients, but it affected doctors really bad.
So, can you talk about that for a minute?
Sure. Yeah, it's something, again, no one's ever heard about, but it was a very similar system. Okay. It was called RAC audits, or recovery audit contractors. Okay. And I'm going to date myself. This is about 10 or 15 years ago when I was, early on consultant. I did a lot of medical practice consulting. I don't do that anymore, by the way. So don't email me. I don't do that work anymore. But anyway, back then that's what I did. And I helped a lot of practices with, things going on in their office, everything from marketing to billing. And there was this thing that came out called recovery audit contracts, or RAC audits. So let me walk you through what happened here. So Medicare got empowered by Congress to go out and hire for-profit companies. Sound familiar? And these for-profit companies would come in and audit the records of doctors and determine whether or not the doctor should have done the care or not. Okay. So whereas right now in the Wiser program, we're hiring a third-party company that's going to get paid for going out and looking at patients' decisions before therapy. But here, RAC audits were actually done after therapy. Now, you might hold your hand up and say, well, wasn't that the right way to do it? Except these companies were also rewarded on how much fraud, waste, and abuse they found. So let me kind of walk you through a simple scenario. I got hired by a practice who had a RAC audit. RAC audit came in and pulled 20 charts from the practice, and they found that the practice owed about $350,000 in overpayment and sent a bill to the practice for $350,000. I got
And
called
let
in.
me stop you here. When you say they owed about $350,000 in overpayment, what exactly do you mean?
Well, it means that the RAC auditor determined that Medicare had overpaid them $350,000.
So they charged for procedures. They charged more than they should have.
Yeah, most of the time it was things like they, if you rank, like you should have charged a level 3, they charged a level 4.
Okay.
Maybe many times I think they were only allowed to give 10 milligrams of drug to a patient, but the patient was really sick and they got 20. They billed for 20, but Medicare only covers 10. So they disallowed the extra 10. Keep in mind, the patient got the treatment, got the therapy, probably needed it from the doctor. So I get hired to come in and say, help them out. So of course we hired an attorney. We fought it, with the attorney. But the bigger things that we did is we implemented a lot of changes in the practice. We put in an electronic medical record at a cost of about $150,000 back in those days. We put in auditing procedures, meaning we would audit charts on our own. We brought in training. We trained the staff on correct auditing. We trained the physicians on correct coding. We started to do regular cold audits, meaning we would put in systems where we would pull 10 to 20 charts a month and pay to have them professionally audited to see for problems and trends so that we could pick up on them and actually fix them. The practice was full bore in making this improved. 18 months later, we get that practice got a repeat rack audit. They pulled 20 charts. Now, this time we had a system in place. So we looked at the same 20 charts. We found a questionable issue in 1 out of the 20 charts. 19 pristine. The rack auditor came back and said 17 charts were denied. Exactly. Now, I'll be honest with you. I successfully argued with the rack auditor to say bullshit, for lack of a better word, and we were able to get that practice from moving out of it. But it just gives you an example that for that 24-month period or so, the practice had this hanging over their head. They had spent $700,000 between the audit findings and the improvements and the repeat audits. And what did we accomplish from all that? Nothing. Because in reality, they came back and said we still had 17 charts, so they didn't have to pay anything on that second audit. But the point I'm going here is that this is an example of these draconian style systems that are put in place with not a lot of oversight, where people get paid for finding problems. That's wrong.
That's what I was going to say. I mean, I'm not great at math, so I'm having to follow some of what you're saying here. But what I hear you saying is this is an example of what happens when a company is paid, gets a cut for denials.
Right.
Is that correct?
Correct. And honestly, in insurance companies today, really, that's not allowed. Insurance companies have to follow medical policy. And so they're not really paid on that. Now, you could argue that in fully insured plans and things like that, but there are so many rules on it because it's been around so long. And let's be honest, years ago it was probably abused. And so that's led to a lot of changes in the insurance industry. It's very mature. Not going to say that you're not going to end up having a problem with a denial and that insurance companies may not be the most responsive and still have to go through kind of an archaic phone system to get it fixed. That's all true. But at the end of the day, there is a pretty established kind of, I don't want to call it case law, but let's just say pretty established formula on how it actually works. And that's not here. I don't see that going on here.
One of the other terms that I saw in the blog post that you wrote was the great expansion trap. Can you address that?
Well, I think I was referring to there that, you've got a system here with Medicare, which is fundamentally, we've never done this before. We've never put a burden on a Medicare consumer to impede their ability to get care. You think of it like a hurdle, okay? I mean, care delayed is care denied. So if you can figure out ways to delay care, right, then you're going to actually end up de facto denying it. Because some people are just going to get better, they're going to give up. It's not going to get delivered. Medicare has never really had that. Didn't have to have a prior authorization. Don't have to have a referral from your doctor to see a specialist. You can go wherever you wanted. This is an example, and to me, the biggest fundamental change in Medicare for participants since the system started. Every other system, if you think about in Medicare over the years, most of the time, Medicare, innovations have been expansion. It's been like, we're going to cover drugs. We're going to provide some sort of dental benefit, right? There have been what I would call expansions of the program. Here you've got potentially kind of an impediment in the program or a limitation.
What, in your opinion, are we trading away?
Well, I think we're losing. I mean, to be blunt, I think we're losing sight of the forest for the trees here. I mean, everybody knows that Medicare is unsustainable. There's too much fraud, waste, and abuse. And let me be frank. I think AI will play a huge role here. Okay, I think AI could be sent to goodness here, not necessarily used for badness. But we have to do some things to fix the problem. I just think we can't be reckless in the way we're doing it. And to me, these kind of programs appear to me to be reckless. I think there are so many better opportunities to improve access to care, to put in place things that focus on outcomes rather than payment. keep in mind also that most of the physicians that are in the system in that sort of journey with the patient, they haven't had a significant Medicare pay increase in decades. So it's not like you're dealing with a crowd of doctors out here who are trying to overuse and abuse the system. Don't get me wrong, there are bad actors out there, but by and large, huge number. And when I say huge, 97%, eight, probably more than that, physicians in this space, they're just trying to help their patient.
So I don't want to get into a lot of detail on this because this is almost a whole other interview. But you mentioned that there are better ways to do this. Can you give me just one brief example that would focus you mentioned focusing on outcomes as opposed to denials, which sounds good to me. What do you mean?
Well, I mean, I think let's just pick an easy one. Patient-centered medical homes, right? I mean, being able to pay your primary care physician more to manage your care better, okay? And to be able to supervise the utility of those treatments. So, you talk about that cervical injection. Who's going to know better about whether or not that would really be a good treatment for that, for your ex? You could argue that the person giving the injection may have some kind of economic incentive in there to overuse it, but your primary care physician wouldn't. And your primary care physician that's overlooking your care doesn't really get reimbursed anything by Medicare for overlooking the care of their patients. So that's one example. Prescription drugs. I mean, a huge cost in Medicare is prescription drugs. And we've talked about that before, but there's lots of reforms that can happen on prescription drug pricing that would have a serious improvement on cost that probably would be would be completely transparent to patients. They would never see what was going on. They would know that their process were better. So I think there's a lot of things that could be done that are better. To me, I think this is ill-fated. And if it works, if it sticks, it's going to be a fundamental change in the way Medicare is delivered in the United States.
So you have some ideas on what people should do because you and I talked about this, and I think you said that you think it's too far down the road. It's not going to be rolled back, that they're going ahead with this. So question is always, what are we supposed to do?
Well, I think it is going to happen. I mean, I don't think it can be rolled back. I mean, the way it was built, in just putting politics aside, the way it was kind of implemented, it makes it difficult for Congress to say make an immediate change. So I don't know that calling your congressman is really going to have much immediate effect. Although I don't think it's a bad idea to do. I think we're going to have to really kind of see what kind of effects happen. It could be that the sky is falling. I'm a little chicken telling you the sky is falling. It could be that it turns out that they approve everything, and it's only the really bad actors that end up being the problem because the tolerance on what they deny is really low. I don't know. So I think we're gonna have to wait and see. But if you do go through the system, I think there are some things you can do. I think one, be proactive. Be very proactive with the system. There are phone numbers you can call that they're going to publish that supposedly will have guidance counselors to help you manage that process. And I would say at this point, learn a lot about it. Learn that there are going to be some changes in your benefits going forward. And specifically, if you have one of these conditions and you've yet to either have the treatment but it's on the radar somewhere, or if you're currently getting some of these treatments, just be aware that there could be some issues on January 1st.
One of the things that I've suggested on my social, where a lot of people have had questions about it, is I've just said, talk to your doctor now before 2026 rolls around. I don't know, maybe that procedure that's scheduled for 2026, maybe that procedure could be done now. Maybe is that legit advice or not? I'm just a
I don't
patient.
know. I'm not a big fan of doing procedures until you need them. So that's the other problem I have, is that, why I wouldn't want somebody to go get a cervical fusion, just because it might not be covered later. I think I wouldn't ever recommend doing that. I think you should get that procedure done when you need it. But the point is, when you do need it, you should be able to get it done, right? You shouldn't have to worry about these rules, which is one of the reasons I have a problem with them. And the second thing, you made a good point about talk to your doctor. This is absolutely no fact what I'm about to tell you. I would not be shocked if 50% of physicians aren't really aware of these programs. Now, I think if you're a physician that's engaged in these treatments, you're probably aware of it. wouldn't shock me at all if this is news to your primary care physician. It was news to me, and I'm immersed in healthcare. So when I read about it, I thought, okay, this kind of silently came out,
Yeah.
and but to me, this is really, to me, a fundamental shift in the way Medicare is reimbursed in the U.S.
So I know I know that you're an former insurance company executive. I know that you're the builder of a lot of AI products, but I think at your heart, you're an MD and a physician. As a doctor, a caretaker of others, just any closing thoughts on this subject?
I think if you sit across if you're sitting across an exam table from a patient, and as far as a guiding principle for me, if you make the right decision for the patient and you put in place policies that are the right decisions for populations of patients, guess what? Things tend to turn out okay. If you tend to look at other things to make your decisions, like financials or politics or whatever you want to look at, the person that gets harmed is the person sitting across the table in the exam room. So to me, the guiding principle for me has always been what's in the best interest of the patient. And I would argue this policy I would have grave concerns about.
Where can people find you to find more in health related information?
Well, they can reach out to me on LinkedIn. That's real easy to do. So if you're on LinkedIn, reach out to me there. You can just send me a direct message. And also you can connect with me we'll put my credentials on your YouTube channel. And also you can reach out to me on Instagram, Facebook, Doc Dano. It's pretty easy to find. And I have a blog as well where I write about this information. So thanks for sharing me. I had a great time.
Thank you, Dan. So appreciate your information on an important subject
Thank
for
you.
all my fans and followers. We really appreciate it. So I'm
Well, thank
speaking
you.
on their behalf. Thank you
Great.
very much.
Thank you. Have a great day.
Great seeing you. Thank you. You too.